Hello, friends. Today we will discuss if you know how you defecate. I am Dr. Jagajit Singh Virk, MBBS, FCGP, FAMS, PGDGM. First of all, I will give you a small glimpse of anatomy of our gastrointestinal system. Here is stomach. It starts with duodenum, which is a C-type tube. Then there is duodenojejunal junction, and jejunum is all this jejunum is there. Then it becomes ileum at this place, and this is ileocecal junction where it meets the cecum. This portion is cecum of the large intestine, and here comes the appendix. Now, this is the ascending colon. Here, this is the right flexure, and this is the transverse colon, and this is the left colic flexure, and this is the descending colon. This is sigmoid colon, and this is rectum, and this is anal canal. Our food which we eat first comes in the stomach, then in the small intestine, duodenum, jejunum, and ileum, and then it goes to the cecum, and then here the colon, and then it is sigmoid colon, rectum, and then it passes away with waste products through the anal canal. This is our gastrointestinal system, and here I would like to tell you that this is a pancreas, which is behind the stomach, and this is the gallbladder, and here gallbladder and pancreas both opens into the duodenum, and here is the common bile duct, which comes from liver and gallbladder. This is liver, and this is almost the whole of the gastrointestinal tract, and affecting our food for its absorption, for its assimilation, and sending waste products to the outside world. Now, what is defecation? The term given for the act of expelling feces from the digestive tract via the anus. It's a complex function that requires coordinated involvement from the gastrointestinal system, the nervous system, as well as the musculoskeletal system of the body. The frequency of defecation within a 24-hour period varies depending on age and diet. But most people tend to have a bowel movement 1 to 3 times daily. This is the picture of our colon. As I have told you, this is appendix, this is cecum, this is ascending colon, transverse colon, the descending colon, this is sigmoid colon, and this is rectum, and this is anus. Here, I would like to tell you that this is a small portion of microscopic structure of our wall of the colon. This is mucosa, this thick one. Here I would like to tell you the muscles. These two layers of muscle, the inside is the circular muscles, and outside is the longitudinal muscles which help in defecation. As I have told you that these muscles, when contract and relax, these muscles help in defecation. control of defecation. Lining of the anus and rectum primarily is a columnar epithelium. This shifts to squamous epithelium in an area known as the transitional zone located just superior to the dentate line. Two sphincters control the act of defecation. The internal anal sphincter consists of circular smooth muscles cells under involuntary control. That is not under our control. Whereas the external anal sphincter consists of longitudinal, voluntary controlled striated muscle cells, just like our muscle cells of our thigh and other somatic muscles. Organ system responsible for defecation. Colon for propelling feces toward the rectum and beginning the urge to defecate. External anal sphincter and the puborectalis muscle, which gives a kink to the colon muscles, relax to allow the passage of feces out of the rectum. Valsalva maneuver and abdominal muscle contraction to increase intra-abdominal pressure, expel feces more rapidly. Rectal afferent nerves for the sensation of rectal fullness and the urge to defecate. Sacral nerves S2 to S4 supply innervation to the muscles in the act of defecation via the pudendal nerve. Function of the defecation. Defecation is necessary to expel the waste products, undigested portions of food, metabolic waste products like stercobilin from the body in the form of stool. Stool also contains bacteria in abundance, cellular debris from the gastrointestinal tract. Mechanism of defecation. Colonic mass movements and peristalsis move intestinal contents distally into the rectum. Rectal filling activates mechanoreceptors in the rectal wall, causing awareness of the need to defecate. Stool reaches the rectum. A small amount is allowed to pass through to the anal canal by an involuntary relaxation of the internal anal sphincter. Action known as the recto-anal inhibitory reflex is necessary for anal sampling, which is the process of determining if the rectal contents are of the gaseous, solid, or liquid form. So we can know whether to pass it or not. At this time, if defecation is not socially acceptable or convenient, the rectal wall relaxes and the need to defecate subsides temporarily. If it is a proper time to defecate, person generally either sits or squats depending on their environment and situation. Next, contraction of the abdominal muscles and performing the Valsalva maneuver while simultaneously relaxing the external anal sphincter and puborectalis muscle will expel feces from the body due to the pressure gradient generated between the rectum and the anal canal. Mechanism. As feces exit, the anus is drawn up over the passing mass by muscles of the pelvic diaphragm to prevent prolapse, that is pushing out of the body of the anal canal. While defecation is occurring, the excretion of urine is usually stimulated. The chest muscles, diaphragm, abdominal wall muscles, and pelvic diaphragm all exert pressure on the digestive tract. Respiration temporarily ceases as the filled lungs push the diaphragm down to exert pressure. Blood pressure rises in the body and the amount of blood pumped by the heart decreases. After fecal expulsion, the closing reflex occurs, which involves the external anal sphincter regaining its tone to maintain continence at rest. Food, movement, and reflexes. Gastrocolic reflex, one of the three extrinsic physiological reflexes that control the motility or peristalsis of the gastrointestinal tract. It involves an increase in the motility of the colon, creates the urge to defecate along with the gastroileal reflex, and helps make room for food in the stomach. Enterogastric reflex, one of the three extrinsic reflexes of the gastrointestinal tract that is stimulated by the presence of acid levels in the duodenum or in the stomach. It releases acids and controls the release of stomach proteins such as gastrin. Gastroileal reflex, one of the three extrinsic reflexes of the gastrointestinal tract that works with the gastrocolic reflex to stimulate the urge to defecate. This reflex is stimulated by the opening of the ileocecal valve and moves the digested contents from the ileum of the small intestine into the colon for compaction. Defecation reflex. There are two main defecation reflexes. The myenteric defecation reflex is responsible for increasing peristalsis and propelling stool toward the rectum. This eventually signals the internal anal sphincter to relax and reduce sphincter constriction. The second type of defecation reflex is the parasympathetic defecation reflex. While the motions of moving stool are similar, a person can voluntarily control the parasympathetic defecation reflex, but they can't control the myenteric one. It's possible that a person can have a myenteric defecation reflex without the parasympathetic reflex. When this occurs, the urge to go to the bathroom may not be strong as when both reflexes are working. Medical conditions affecting this reflex. Gastrointestinal irritation. A stomach bug or other intestinal infection can make some nerves more irritated and others less likely to work. Neurological or brain disorders. Damage to the nervous system can affect the transmission of messages from the brain to the muscles of the anal sphincter and vice versa. Examples include when a person has had a stroke or has multiple sclerosis or Parkinson's disease. Pelvic floor disorders. Conditions occur when the pelvic floor muscles that are responsible for pooping, peeing, and sexual functions don't work as well as they should. Conditions include rectal prolapse or rectocy. Spinal cord injuries. When a person has had a spinal cord injury that causes them to be a paraplegic or quadriplegic, the nerve signals don't always transmit normally. Those with quadriplegia tend to have significantly more difficulty with the defecation reflex. Pathophysiology. Pathophysiology associated with defecation can subdivide into the following three conditions. Number one is diarrhea, number two is constipation, and number three is fecal incontinence. Diarrhea. Diarrhea is an increase in stool frequency, liquidity, or volume of the stools. It further subcategorizes into the following types: secretory, osmotic, inflammatory, and functional. Secretory diarrhea. Secretory diarrhea is caused either by decreased absorption of the water in the colon or increased secretion of electrolytes and water by the intestinal epithelium. Commonly occurs in the setting of certain infections by certain bacteria like Vibrio cholerae in cholera, or with certain malignancies that increase secretion, such as a lipoma or carcinoid tumor. There are many medications that can increase intestinal fluid secretion, as well as such as zidovudine and irinotecan, among the long list of others. Osmotic diarrhea. Osmotic diarrhea is characterized by a substance such as lactose or gluten drying water into the bowel down the concentration gradient. Diarrhea will frequently occur in malabsorption syndrome such as lactose intolerance or celiac disease. Can also result from the ingestion of osmotically active substances like magnesium or sulfate, which are common ingredients in laxatives. Inflammatory diarrhea. Inflammatory diarrhea will occur in inflammatory bowel diseases, Crohn's disease or ulcerative colitis, certain invasive intestinal infections like Clostridium difficile or Shigella. In inflammatory diarrhea, the stool will contain blood, white blood cells, along with mucus. Functional diarrhea. The most common form of functional diarrhea is irritable bowel syndrome, one of the functional gastrointestinal disorders. This syndrome is often considered a diagnosis of exclusion. Exact etiology is unknown, but it may involve alterations in the microbiome of the intestine, in addition to the rapid transit time of contents through the digestive tract. Constipation. Constipation involves a decrease in defecation frequency, generally occurring 3 or fewer times per week. This can lead to hardening of the stools and straining when attempting defecation. Constipation can be a side effect of many medications, often those that slow intestinal motility, such as medications with anticholinergic properties. Can also be a result of a low fiber diet or disorders that disrupt the necessarily coordinated muscle contractions for defecation, such as multiple sclerosis or spinal cord injury. Constipation treatment. You should take steps to make stool easy to pass. This can include drinking plenty of water, eating high fiber foods like fruits, vegetables, and whole grains. You also shouldn't ignore the urge to poop when you feel it come on. A doctor may recommend taking stool softeners to make stool easier to pass. Fecal incontinence occurs most frequently in the elderly and is the inability to control the passage of stool. It can be congenital, such as in the setting of spinal cord defects or anorectal malformations, or it can be an acquired condition often associated with an injury occurring during labor or anorectal surgery. Thank you very much.